Good morning, everyone. I'm Muriel Bowser. I'm the mayor of Washington, D.C. I'm joined today by members of my administration, Dr. LaQuandra Nesbitt, who is the director of DC Health, and Dr. Chris Rodriguez, who is the director of DCH SEMA. Before we begin, I want to congratulate our neighbor and friend, Susan Rice, who we understand has been tapped to lead the Domestic Policy Council for President-elect Joe Biden. She will have a significant role in shaping the administration's priorities, including economic and domestic policy. We know Susan, of course, is an absolute home run of a selection. We saw her leadership firsthand this year as she co-chaired our Reopen DC Advisory Committee to help us with our phase reopening. Now she will help reopen the nation, and we could not be more proud of her participation in the incoming administration. I also want to remind every day that today is National Get Covered Day, so we continue to encourage DC residents to sign up for high-quality, affordable health insurance through DC's marketplace. You can go to dchealthlink.com for more information. DC residents have until January 31st to get covered, but please don't wait to sign up. Go to dchealthlink.com. I also asked my team to look into something that I know a lot of DC residents have been harassed by, quite frankly, by calls to landlines and mobile phones that we know to be a Social Security scam. So I asked Director Rodriguez to look into it and provide us an update.
Thank you, Mayor Bowser. Over the last several months, we've identified, and in some cases our residents have been victims of a what appears to be a national Social Security scam. And this scam is really playing out by scammers calling cell phone numbers from a variety of different landlines or cell phone numbers, essentially spoofing those numbers and making them seem legitimate to someone's cell phone. And on these calls, there are scammers that are asking for Social Security numbers or threatening the recipient on the other line of the call with any legal action or fines if they don't provide Social Security numbers or provide personally identifiable information. We want our residents to know that we've been in touch with the federal government about this scam. They have provided us with some good information and some tips for victims of this scam. The most important thing for our residents to know is that the U.S. government does not suspend Social Security numbers. It does not typically contact citizens or residents by phone or by email and ask for personally identifiable information. Most of that communication happens through the U.S. Postal Service. And we also want our residents to know that any entity that's unsolicited that is trying to contact you, you should not be giving any type of personally identifiable information or Social Security numbers to anyone who you do not know or you don't know why that communication is coming to you. And to report a scam, please go to oig.ssa.gov. The Social Security Administration has set up a website and a portal for residents and citizens to report any scamming activities. So with that, thank you, Mayor.
Thank you for that, Director Rodriguez, and we'll make sure that we post this information and get it out on all of our platforms as well to remind people of that critical information that we gathered about your Social Security card and how you should never provide that information. Now we want to turn to our COVID update and the reports of the metrics that we report each day, and that DC Health continues to follow closely. And Dr. Nesbitt will be available to answer any questions about that. We also have additional data to report this morning. When we met on Monday, Dr. Nesbitt mentioned that her team would be conducting a community mask audit, and I want to turn to Dr. Nesbitt to discuss the results.
Sure, thank you, Madam Mayor. We conduct a mass audit every few weeks where we deploy a number of individuals from the District of Columbia Department of Health who are part of our DC Contact Trace team so that they can observe behaviors and patterns of our public as it relates to compliance with the mayor's order that mandates the wearing of masks in the District of Columbia. On our most recent audit that was conducted from November 18th to December 9th, we deployed our team members to 151 locations across the district, covering all 8 wards. Over 4,250 individuals who were observed. 78% of individuals met the DC mask guidance criteria for being required to wear a mask. However, only 72% were wearing the mask correctly for the entire time that they were observed. So we want to make sure that individuals are always covering both the nose and the mouth. Is the most common thing that we observed with people not wearing it correctly, so that there's often slippage where the nose is not adequately or properly covered. So it is pretty good coverage compared to what other jurisdictions have. And we wanted to do this mask audit instead of relying on some of the surveys that are often used on social media because we don't have all of our population who would be represented in what we call those convenient samples. In this slide here, you can see the results broken down by age group. You can see that we have some work to do with our younger populations. We know that it could be a little bit of a challenge for a rambunctious younger person to use a mask, but also making sure that we get compliance with our teenage population when they are out and about, especially when they are out by themselves, not supervised by adults. There is better compliance, we know, in structured environments where there is supervision of young people, but when they are unsupervised, playing as in groups, there isn't always the best compliance. And so make sure that we can communicate and stress the importance of young people of always wearing their mask and wearing it appropriately when they're socializing amongst themselves. We also have some wanting to emphasize again that our seniors are leading the way and being good examples for us in the age groups. Comparing men and women, women or females are required to, who are required to wear a mask, wear their mask correctly more often than men. And finally, we have breakdowns by ward. And the highest percentage of individuals observed wearing a mask correctly was Ward 2, and the lowest percentage of individuals wearing a mask correctly was in Ward 7, with a noticeably huge gap there in terms of those observations. And that's all we have for our mask audit findings, Mayor.
Well, thank you, Dr. Nesbitt. I want to thank all the team who was out in the community across all 8 wards with those observations. And certainly that information will help us in our messaging in reminding people how to properly wear masks. Further, we want to just provide an update on the holiday guidance. Washingtonians are again strongly encouraged not to travel for the holidays and to celebrate at home. On another update, we have received in the last several weeks, we have, I should say in the past week, recently the CDC has updated its quarantine guidance, and we have thus updated our guidance to coincide with it. The DC Health has updated our guidance for close contacts to say that ending quarantine after 10 days after an exposure may be acceptable if you do not have symptoms and you continue to monitor for symptoms up to 14 days after the exposure. So that guidance has been updated on our website. We want to note, however, that healthcare facility and congregate setting staff, residents, and patients, nothing has changed for them, and they must continue to adhere to the 14 days of quarantine after an exposure. Now I wanted Dr. Nesbitt to provide a detailed update on where we are with the deployment of the vaccine. I'm sure everyone has been watching the news, and this information is in a constant loop, but we'll provide some detailed information about our deployment. Dr. Nesbitt.
Yes, thank you so much, Madam Mayor. And as you have mentioned, we have done a lot of work in terms of implementing what we call the non-pharmaceutical interventions in our community, in terms of the things that we've just highlighted and around mask usage. And with your leadership, we have one of the most robust, if not the most robust, testing programs in the country. But now we have the opportunity to have our pharmaceutical intervention, which is the vaccination campaign or vaccination program, which is that light at the end of the tunnel that we've often talked about and referred to. We've been preparing since the summer for this vaccination campaign and have purchased a number of supplies with over 184,000 needles and syringes, 1 million alcohol prep pads and Band-Aids, as well as other supplies needed to vaccinate the public. Additionally, on March 13th, we issued an administrative order to modify the scope of practice for certain licensed, registered, and certified healthcare providers as required, including authorizing certified paramedics to administer vaccines with appropriate training and supervision. The district currently has 176 provider agreements with hospitals, pharmacies, long-term care facilities, clinics, urgent cares, and other healthcare facilities. And these agreements will allow providers at those locations to order and administer the COVID-19 vaccine in Washington, D.C. And so by now, many of us know that it is possible that the FDA could grant emergency use authorization for the Pfizer vaccine in the next few days. Once that happens, we won't be able to start giving out the vaccine right away because a few additional things will need to happen. First, the CDC Advisory Committee on Immunization Practices must issue recommendations for vaccine distribution. They have already provided some interim guidelines and recommendations at the beginning of the month, but they will also work collaboratively to make a decision around whether or not those will remain interim or if they will make some updates. Additionally, the CDC will provide what's called vaccine information sheets or guidances that explain to more in a lay way what the emergency use authorization entails. That will allow for vaccinators to then be fully trained to administer vaccines. So while logistically vaccine may be able to be deployed to communities within a day of the emergency use authorization approval, there is still other things that need to be put in place at the community level to ensure that vaccinators, healthcare providers have all of the information that they need to safely vaccinate the public, and that members of the public can receive all of the information that they need from vaccinators or healthcare providers to make informed decisions about their choices. Once the vaccine is approved, 6 sites in the District of Columbia during our first initial phases of Phase 1A will receive the vaccine because they have the necessary equipment to store the Pfizer vaccine. And the district will receive 6,825 doses in its initial allotment, as the doses are in a box of 975 doses, and we'll receive 7 boxes. Those 6 sites are listed below at MedStar Washington Hospital Center, Howard University Hospital, the George Washington University Hospital, Children's National Hospital, Kaiser Permanente, and MedStar Georgetown University Hospital. This week, the team at DC Health has conducted reviews of those hospitals' plans, as well as on-site inspections to ensure that they are ready to receive their supplies. Now, you will note that all of the district's acute care facilities are not noted here, or all of our specialty hospitals, because we have what we call a hub and spoke model that will allow those primary receiving facilities or institutions to partner with other healthcare sites and provider organizations to be able to vaccinate the initial phase 1A healthcare worker groups. So for example, Children's National will partner with United Medical Center to provide them vaccines, and Kaiser will partner with DC government to vaccinate EMS workers as well as frontline public health workers. Consistent with CDC guidance, the District of Columbia will implement a phased approach to vaccination. And we also talk about that in a little bit more detail as in terms of a phased rollout of a phased approach. So within each one of these phases, phase 1A, primarily being healthcare workers and first responders, phase 1B, essential workers and at-risk residents, phase 2, the rest of the phase 1 populations in the general public, and then phase 3. We note that each phase does not have to be fully vaccinated before we move on to the next phase. We will take into consideration factors such as acceptance and adoption of the vaccine before we make decisions of moving into subsequent phases. You will also note that when we talk about who is included in each phase 1A, and our previous statement that 6,825 doses will be received in the first week, it is not possible to vaccinate an entire phase at the same time. And so there is a further stratification required within each phase. Because of that, we talk about a phased rollout of a phased approach. So phase 1A includes, you can see who's listed there, for example, full and part-time hospital staff, home health providers, emergency medical services providers, and phase 1B, for example, includes certain essential government employees, adults with high-risk health conditions, school teachers and staff, and other critical infrastructure workers such as grocery store employees. And that group is rather sizable with over 300,000 individuals. So who will receive the vaccine first? Out of our initial allotment of 6,825 vaccines, the initial distribution of the vaccine will be tied to settings and not necessarily job roles, and we will begin with those healthcare workers who work in emergency settings, those frontline healthcare workers in those settings. And we have worked collaboratively with the healthcare providers who will be receiving the vaccines to identify those individuals. So just to emphasize, it is not necessarily just the doctors and nurses who work in those environments, but it also includes the techs, environmental services staff, et cetera. So why was this group chosen? Well, there's a lot that goes into these decisions, and a lot of smart and capable people working to identify these priority groups. But at the end of the day, vaccinating healthcare workers first ensures we have a healthy workforce that's available to take care of and treat sick people, and protecting the workers helps to protect the patients.
Thank you, Dr. Nesbitt. So we wanted to make sure we put a lot of information out on the table to let people know what to expect in the coming days, weeks, and indeed months. And we are all very hopeful, but we also know that we have to continue to be vigilant until we can achieve a full deployment of the vaccine. So with that, we'll take your questions. Yes, Sam.
You said there was a case against 6,000 and some for the first week. Does that mean that others are coming the second week, or how does that work?
As the process has been described, thanks for the question, Sam. As the process has been described to us, we are to anticipate receiving or being able to access additional vaccine on a weekly or every other week basis. Our ability to access that vaccine is contingent upon the production schedule of the manufacturer and how the demand for vaccine within our community. So we are responsible for communicating back to the CDC how much vaccine has been used in our community out of that original allocation of 6,825 doses. And then they will release to us additional doses of vaccine that we can request be shipped here for use. And those doses will be made available to us through the ordering system on a weekly or every other week basis.
And so a Joe citizen out here that meets some of these categories, what do? Do they contact somebody, or what happens?
So it's more of an outreach than an in-reach in the earlier phases. So individuals who are healthcare workers will be notified through their employing institution or organization when their category or priority group is up for vaccination. They will receive instructions as to how to make an appointment for vaccination through the entity that will be handling their process. For many people who work in a healthcare system, like hospitals and large healthcare organizations, they will be vaccinating their employees through occupational health programs. For our healthcare workers who work more in the community settings and outpatient settings, they will have access to vaccines through health centers, through commercial and retail pharmacies, and they will have access to a technology solution that allows them, once they receive notification that their priority group is up for vaccination, in terms of how to register for an appointment to get vaccinated at any of those locations that are convenient for them.
The average citizen really shouldn't do anything.
We're not yet to phase 1B, where more citizens, I hate to use the word average, because every person has their own unique set of circumstances that would make them eligible for the vaccine at different times. So some people who are above the age 65 are going to be eligible at certain periods of time. People with certain health conditions are going to be eligible at a certain period of time. And as those criteria are announced, they will receive instructions, and we'll make those instructions public in all of the different ways that we do in terms of how to register. And a lot of these things are going to be able to be done. As I mentioned before, we have over 170 healthcare provider organization types that have registered to be vaccinators. So that includes doctors' offices who are working with these individuals who meet this criteria.
Yes.
Hi, I'm Lola with the Washington Post. I just have a clarifying question. Are the 6,800 doses for all of phase 1A, or is that just what is expected for that first shipment?
So we have over 85,000 individuals who meet the criteria for phase 1A. So we expect to receive an allotment from the federal government that will be sufficient for us to vaccinate that entire group. So 6,825 doses is just our first initial allocation.
Okay, for that entire group, so there could be more?
We absolutely expect that we will receive
Okay.
more vaccine.
Okay.
Yes.
A couple of questions. When you talk about doses, are you including the first shot? Because they have to get two, is that right?
That is correct.
So when you get a dose, do you get the first and the second round, or does the second round come later in a second shipment?
We have not instructed healthcare providers to hold the second dose for the individual out of that first 6,825.
The exact same thing then, the vaccine. I'm
It's
just
one
wondering if
dose.
it's I'm sorry?
You're saying, is it one
So-
dose or is it a pair of doses?
Let me answer, so if I answer it this way, we are not expecting to only vaccinate 3,400 individuals out of these first set of doses.
Okay, and then do you have dates? Can you put any kind of dates on when you would actually begin administering, for phase 1A, phase 1B? Do you have any kind of timeline you can give people?
It's impossible to do that, and I would surmise that anyone who is doing that is ambitious. And the reason why I say that is that no one is bound to create an emergency use authorization today, right? There's an advisory group that's meeting today, and the commissioner of the FDA should be given the time that he needs to make meaningful decisions that are deliberate, right? We all are very excited about the opportunity to vaccinate our communities, but we need to have the processes be as deliberative as they need to be to get the right types of documents that are thorough, that communicate the right type of information that we need so we can have a safe and effective process at the community level. Once the EUA is published, the CDC needs the time that it needs to create meaningful vaccine information sheets. What a vaccine information sheet is if any of you have been to the doctor and you've gotten a vaccine, an influenza vaccine, if you've taken your children, if you have them to the doctor to get any of their childhood immunizations, you get a document that essentially tells you what to expect through the vaccination process, why you're being vaccinated, what you should expect that day, what you could expect days afterward. The CDC cannot produce that vaccine information sheet until there is an EUA that gives who the vaccine is indicated for, why it's indicated for that group, if it's contraindicated in any population. They can't produce those documents until there is an EUA. And the number of days that they need to do that process is dependent on any complications or how complex the administration of the vaccine is. All of us would want a healthcare provider who is going to be administering a vaccine to us to have sufficient time to be trained on that specific vaccine. Some vaccines require mixing, some of them don't. Some of them have unique storage properties or requirements, some of them don't. This vaccine comes in its own unique container. That container can only be opened twice a day. So you want people to really be able to be trained on those things. So for me to make to give you a date certain by which all of that would be completed would not be wise. The second part of it is we're getting 6,825 doses. We want to vaccinate the 85,000 people in the district who work in the district, regardless of their place of residence, right? So there's some factors in terms of how many of them are going to be willing to get the vaccine, how their perspectives around the vaccine may change during that eventual phase 1A. How quickly we can get to phase 1B depends on if the federal government is going to increase our allocation, if I'm only going to keep getting 6,825 doses at a time, if I get that every week, every 2 weeks, right? So there's a lot of factors that determine how quickly we can move to phase 1B.
And so if the federal government, everybody had everything that they needed, the EUA and whatnot, in order, how many days after that you receive the shipment could DC start administering the first round of those 6,000 vaccines?
Once we have it, is your question? Once it has been delivered to us?
Once it is delivered to us, it depends. Because logistically, Mark, the Department of Defense is saying that they could give us a vaccine the day that the EUA is assigned. That's nothing to figure in the number of days that the CDC needs to create a document that explains how the vaccine, the vaccine information sheet, which is a critical part of training, right? So getting the vaccine physically here as a matter of logistics is not the hardest part of this work, okay? Clinically training people, being able to answer questions that clinicians have, being able to answer questions that clinicians will have to answer to patients is the harder part of the work.
Yes, James.
Dr. Nesbitt, basically got 3 quick questions. Number one, you have people in the city that might not have access to this type of information readily like we do. Is there going to be a public information campaign about the phases that you just talked about? Number 2, as you know, in Maryland, they have a medical corps, and the governor there is encouraging retired medical professionals to get involved in terms of helping to fight COVID-19. Do you have a similar program like that here in the district? And, yeah.
Yeah, when you told me you had 3. I was waiting.
I forgot the last.
That's okay. So yes, we have a medical reserve corps, and we activated our medical reserve corps months ago, and we have been using them ever since in a number of ways, and we will continue to do that. Our Medical Reserve Corps has helped to support initiatives around testing. Some of them have come on in other ways related to our epidemiology work and our contact tracing work, and many of them are standing by to assist us in our medical surge efforts as well. As I mentioned in our opening comments, we have been able to also do things around our administrative orders to allow for some changes in scope of practice, but also for reciprocity, where our healthcare facilities can bring in healthcare workers who are licensed in other states and their license is in good standing, and they can work under the supervision or credentialing of their healthcare facility as opposed to having to get a full license in the District of Columbia. So we've done a lot of that work. We did that work back in the spring, and as well as heavily and mightily recruiting members into our Medical Reserve Corps. So we have brought in many of our retired healthcare workers into our system. In terms of the public information campaign, we have been working, and we have the infrastructure for our public information campaign around this work, not just around the phases of the campaign, but also the messages for those who we know will be hardest to reach and those for whom we have to build lots of confidence in the vaccine. That infrastructure for that campaign is ready to go, and we'll hit more of a full throttle as vaccines get approved. And we have confidence, I shouldn't say more, but we have full confidence in the actual types of vaccines that have been approved, where we're going to be standing behind them fully with that FDA approval. And those messages will be focused in certain communities. And then they're on top of a larger mass vaccination campaign. We've already put some toolkits together for healthcare providers. We've done some focus groups. We've been speaking to members of our scientific advisory committee for a while. We pulled a smaller group of them together, those who work very closely with the faith-based community, as well as those who work with some of the special populations that we want to be more focused on, the African American and Latinx population for whom we've surveyed the city, and we have higher rates of hesitancy with the vaccine in those groups.
I remember my third question.
Okay.
At some point in time, you're going to bring in AstraZeneca, and you have Novavax possibly out of Gaithersburg. In other words, you're going to have several COVID-19 vaccines that are going to be around. Have you developed, or has the administration developed a strategy in terms of all of these vaccines?
Yes. So even with the first two, part of our strategy with the first two is because of the complex storage requirements with Pfizer, we're going to keep that vaccine in our our hospital infrastructure that has that storage capacity. And then as the second vaccine comes on board, we'll have more flexibility to put that into more of our outpatient environments, our health centers who don't have that storage capacity. So we'll be looking at some of the characteristics of each of those vaccines and making decisions based on that. But my broader comment to the general public is I would encourage people to take the vaccines that are available as you are in a priority group, and would encourage people not to try to wait for a specific vaccine to become available to get vaccinated. It is more important to be vaccinated as early as we recommend for you and your risk factors, as opposed to trying to wait for a specific vaccine to become available in our market. There may be times when the federal government, just as we are making decisions about Pfizer here because of the storage requirements and Moderna there, that the federal government may make decisions about certain vaccines going to certain regions of the country.
Yes.
Could you describe how the conversations with federal officials have gone about the request to make the allocation based on the healthcare workforce instead of on the population? I know that Mayor Bowser sent a letter last week, but also that this concern was voiced back in October in the distribution plan. So could you sort of talk about where they are on that, what they've told you?
Sure. So early in our conversations with them, there was an appreciation for the request that we were making, and an appreciation for the numbers that we were stating we would have. We voiced those concerns verbally. We documented those concerns in our plan. And at the time, they were consistent with the recommendation that was being made that people should be vaccinated based on where they worked and not where they lived. As they moved forward with some of their more focused policy decisions, we were being told that this firm policy position was being made in fairness, and such that making a decision that would accommodate the request we were making would not be fair. And they've also stated that it would not be equitable. I've studied equity for quite a long time, and equity is giving people what they need. And equality would be giving everybody the same thing. So I think we're overusing the word equity here.
And then just one other question. How does the district plan to vaccinate sort of DC residents who are healthcare workers in maybe Maryland or Virginia?
Sure. So we have a process that when our commercial and retail pharmacies are able to come online as we receive more doses of vaccine, that they will be able to access vaccine in those commercial and retail pharmacies. And that will probably be in the 3rd or 4th week of our campaign.
Yes.
Yeah, some questions about the mask audit. I'm sorry if I missed this at the beginning. Are these indoor or outdoor locations? Are they public areas or private areas? What areas are you looking at?
Well, it's a combination of public areas that are indoor and outdoor. Private areas would mean we would be going into people's homes, if I'm understanding your question.
Businesses?
Oh, we consider those to be public areas if
Okay.
any member of the public can walk into them.
Okay.
Not that they are not privately operated.
Right.
Okay.
Okay, and then what types of conclusions are you drawing from this data? I mean, is there more intervention that's going to be needed to encourage people to wear masks correctly, I guess especially young people? And then also, is there more enforcement that's going to be needed in some of these wards where mask wearing or correct mask wearing is toward the 50% mark?
You want to talk about it?
Yes, we don't anticipate, we anticipate the education route in reminding people of proper mask usage, not defining route.
Okay. And just looking at some of the coronavirus stats for today, the daily case rate has set a record for 7 straight days now. It's at 40%. That's way beyond what the city considers substantial community spread. Is this surge related to Thanksgiving travel? I know you were bracing for a rise during this time period. Is this in line with what you were expecting? Is it worse?
We expected to have an increasing trend if people traveled, got together in groups, et cetera. So, we were optimistic that people would not have traveled and got together in groups. But if they have, and it appears that they did, this is the result.
Okay, and then my last question, the exposure data published earlier this week, looking at the numbers for the week prior that it illustrated, fewer than 1% of coronavirus patients played a sport or went to a gym, while about 18% or so ate at a restaurant. So why have the recent restrictions been more focused on sporting events and gyms versus closing indoor dining or moving quicker to reduce restaurant capacity?
So fewer than reported. Fewer than 1% reported.
Reported, right.
Okay.
Yeah, thank you.
Reported. So I think that's the thing that you all should focus on, reported. And that data, while it can be a rich data set, does have some limitations. And when it does, then we have to focus on the other things that we use in public health to make decisions for recommendations, which are the context and nature of certain activities and the risk that those activities play when they are done in certain settings. I'd ask people to continue to be mindful that public health leaders and practitioners have to use a number of inputs to make decisions on recommendations. So we have our epidemiological data, we have that one data set, then we have case studies and reviews that tell us which things done in which settings create the most risk, and then we have consultations that we do with other colleagues. The absence of something being reported or present in that data does not mean that it doesn't pose a risk in the district. So just continue to keep that in mind, and we can't be put in a position as a health authority to only make recommendations for things that show up in contact tracing data.
Thank you.
Yes, Mark?
Going back to the questions about out-of-state residents, have you coordinated, or are you coordinating with Maryland and Virginia about this Group 1A to see if there's some way to make it most effective? Maryland and Virginia governors have both issued statements saying that they are willing to vaccinate with their allotment their residents who work in DC healthcare systems.
Sure. Two notable comments I'll make about that. The directionality of the workforce is such that we have the greater proportion of workers from Maryland and Virginia who come into the district to work than DC workers going to work in their healthcare facilities. So just bear that in mind when we're putting this in context. Second, I can speak very clearly to the infrastructure by which we are vaccinating and how our healthcare workers will be vaccinated in a setting. I'm not clear that I fully understand how that would happen conversely.
And then, can I ask,
But we have had conversations about it.
You spoke earlier about the allotment, how it was going to happen. You go through your first 6,000 doses, you request another, you expect that to come weekly or bi-weekly. Do you expect the number, I know you'll ask for more, but what are they telling you about what to expect in further allotments? Will it always be this 6,000 number for the near future, or?
No, we don't know. There is no, you don't have like 6-7 weeks worth of allotments programmed into the system.
And so if you were only get the 6,000 a week, I mean, we can do the math there, it would take months to get through.
But I think what the point is, we don't know, and that part of it, we don't have any control over. So the manufacturer of the product, of the vaccine, and also how much is going to be available. And then I know it's unsatisfying as that is, we're kind of, we're working with the unknown and being prepared to deliver as soon as we have the information, we can act on it, but we can't give you information that we don't have yet.
Mayor Bowser, could I ask you, I believe you said that you're going to take the vaccine.
I will.
I'm wondering when. Would you take that right away in the first wave as a way to do a public service announcement like we're hearing?
I would, some people would like me to, but I don't fall into the first wave categories. Dr. Nesbitt does, and she will. Our FEMS providers do, and they will. And I will just as soon as it's my turn. Yes.
I know this is repetitious. How many people are in that first group?
85,000.
85,000. Okay, not hundreds, right?
Okay. Thank you, everybody.